What's going on, everyone? It's Alex here from Alex Physio. So today we're going to be chatting about the cerebellum and what are some tests that we can do to determine whether or not there's an injury to this region. So let's get right into it. The cerebellum is known for the part of the brain that plays a role in our posture, in our motor control, our muscle activity, and our walking pattern primarily. And when there's injury to this region, which is commonly as a result of alcohol poisoning, when a police officer may ask you to walk the line if they suspect that you've been drinking, that can affect the cerebellum and the function of the cerebellum. But there are other reasons that can affect the cerebellum, or other causes that can affect the cerebellum as well. Things such as MS or multiple sclerosis, trauma, stroke, or an injury to the arteries that affect the blood supply that goes to the cerebellum. And what happens is there are functions that are affected in somebody distinctly that has a cerebellar lesion versus another sort of condition that affects the rest of the brain. So what are some of these tests and what are some of these symptoms? So generally they follow the acronym DANISH, D-A-N-I-S-H. The first one, D, stands for dysdiadochokinesia. And this is the inability to perform rapid alternating movements. So if you do have some sort of injury to your cerebellum, a healthcare provider, primarily a physician or a neurologist, will ask you to perform these rapid alternating movements and see if there are differences side to side, if the lesion to the cerebellum had only affected one side. If it affects both, it'd be symmetrical, but if not, you may notice more difficulty on one side compared to the other. So what are some of these tests? The first one is a pronation supination test, which is basically they'll ask you to take your palm of the other hand and try to rapidly turn your palm up and down for about 10 seconds. And what we're looking for is symmetry. Can you do this consistently, symmetrically without issue? Or are you struggling? Are you going, palm down twice, palm up 3 times? Like, is there discrepancy in your ability to perform that movement with appropriate coordination skills and symmetry? So that's one of the first tests. The second test is a finger to nose test. So the examiner would ask you to try to touch their finger, and they're looking to see if you have something called dysmetria. So they're looking to see if dysmetria is basically if you're overshooting the target or undershooting the target. So we're looking again for that symmetry. Are you able to reach that same point on the finger each time? And then if that's easy, then they'll move the finger in different points. So now we're looking at your ability to dynamically find the position on the finger and to be able to touch it. The next one is opening and closing your hands. So again, we're looking to see, can you open and close your hands, making a fist, and then spreading your fingers symmetrically, and is it symmetrical side to side? Okay, and then again, I can ask you to do that for 10 to 15 seconds. So those are a couple of the common tests that look at some of your coordination. So that's D, dysdiadochokinesia. The next letter is A. A stands for ataxia. The examiner would ask you to walk a few steps, and they're looking to see how your gait is, because individuals who have ataxia, they may demonstrate issues with their gait or a cerebellar ataxic gait. What is a cerebellar ataxic gait? It's basically a broad-based style gait, meaning that your feet are wider apart because you're trying to create stability because of the fact that your cerebellum plays a role in your balance. By having your feet further apart, you create a larger base of support to give you some of that improved stability to compensate for your difficulties with your proprioception. Individuals will walk with a wider gait, and they'll trunk lean or they'll trunk V or side to side when they are walking. There may be inconsistencies with their arm movements, and again, it won't be symmetrical. Their gait velocity will be slower, and their steps will be shorter as well, because again, the further the step you take, the more challenging that is for your balance system. So shorter steps maximize the time that both feet are on the ground, making the movement easier to perform or the walking easier to perform. So that's A. A stands for ataxia. N stands for nystagmus. So nystagmus has to do with our eyes, and specifically rapid movements of our eyes. So you're not aware of this, but in your day-to-day life, if you're looking from one object to the next, you don't have to move your head to look at the object, because you can just do it while doing those rapid alternating movements of your eyes. This is controlled by your eye muscles. But when somebody has an injury to their cerebellum, that can affect the ability of our eyes to be able to focus on one point to the next without moving our head. So a test that the examiner would do is we would have their fingers about a few inches off of your eyesight, and you're looking straight ahead, and they're looking to see, can you move your eyes to each finger side to side? Are there any discrepancies in that? And they're looking for the speed at which you can do it from side to side. And if there is an injury to the cerebellum, then individuals will have a hard time doing this movement. It'll either be slower, or they'll have to move their head to compensate for the eye muscle's inability to perform the movement without compensating by turning your head. So that's N. N stands for nystagmus. I stands for intention tremor. So these intention tremors are present in some of those tests that we were talking about earlier, when you ask an individual who has a cerebellar lesion to touch your finger. As they're getting closer to the object, their finger starts to tremor. And the reason for that is it's tremoring as it's getting closer to the target, because it's having a hard time to be able to smoothly just touch the finger and then come back to touch your nose again. S stands for scanning speech, also known as dysarthria. So when an individual with cerebellar lesion is talking, we're looking to see if there's slurring of the speech, because the larynx or the laryngeal muscles are affected, or can be affected, in an individual with a cerebellar lesion. So we're looking for slurring of speech, but we're also looking to see if when they say words, are they breaking them down into syllables? Because sometimes individuals with these lesions, when you ask them to say a word, let's say parliament, instead of saying parliament, they say parliament. So they're breaking that down into its individual syllables in order to pronounce the words. So the last one, H, is hypotonia, where there's basically less resistance to any form of palpation, because that aspect of the cerebellum is basically not using its job. Looking for palpation in the muscle area and looking for any changes side to side in the muscle bulk and the tone, because there should be some muscle tone in an individual without any form of cerebellar lesion. So if you palpate even on your own arms, you can see that you do have some tone without actively having to flex. There is some structure and some resistance to that area. Whereas with individuals who don't have that tone, or have less tone and have that hypotonia, then you may be looking into some more tests to see if the cerebellum is involved, along with some of the other symptoms that we chatted about with that acronym. So there you have it. We talked about the cerebellum, a little bit about its function and what can happen when there's an injury to this region, as well as some of the symptoms to be mindful of that follow that acronym Danish. So D, dysdiadochokinesia, A, ataxia, N, nystagmus, I, intention tremor, S, scanning speech or dysarthria, and H, hypotonia. Hopefully you learned a thing or two about the cerebellum and what can happen when there is an injury to this region. Remember that cerebellar lesions are ipsilateral, so if somebody has an injury to one side of their cerebellum, the symptoms will be on one side only and not the other side, so there'll be differences side to side. If you have a stroke or an injury that affects your cerebrum, so the rest of your brain, or what people commonly associate the brain with, the symptoms are going to be contralateral. So if you had a right-sided stroke, that's going to affect your left arm and left leg, so your left side. Whereas with cerebellar lesions in particular, the lesions are going to be on the same side. So hopefully you learned a thing or two about the cerebellum and what can happen to our function when the cerebellum is affected, and using that acronym that we chatted about as well. If you find value in my content, consider checking out some of my other videos where I talk about physio, medical, and fitness related topics. And if you still find value, consider subscribing. It really helps my channel grow and allows me to reach a wider audience. And until then, we'll see you in the next video.